Okay, on you, Ray. Well, you can begin whenever.
Well, I'm very happy to be able to introduce Mr. and Mrs. Berman and their son Timothy, and they have a story to share with you, my audience, and it's one of those happy occasions that we're very hoping to inspire other people that have experienced head trauma, because we're looking at that in a different way. And I've asked them to just come in and share their own story about their son and what occurred and what their experiences have been. So I'm not going to say any more than that, other than introducing this wonderful family. So thank you for coming.
Thank you.
Well, Timothy's story sort of started when we noticed there was something wrong with him around the holidays of last year, 2017. We noticed that he was not focusing, he couldn't look down, and that his eyesight was just heavily affected, and it came on pretty quickly. So we did the obvious things, took him to an optometrist, had a physical done, and then they said, you guys should probably go and see a neurologist. And we couldn't get an appointment for 2 months. So at a point, I realized this is not a good situation. It was actually his brother's birthday, and I took him to the emergency room. And they did a CT scan, and they said, well, there's a huge mass, and he was immediately transferred from Boca to Delray. And that's kind of where they discovered this huge tumor. Biopsy was done 3 days later.
Yep.
And then a couple of weeks later, was it a couple of weeks?
Yep.
Yeah.
The biopsy had to be sent out of state for,
That's true.
for
That's
testing,
why it took so long.
Took quite some time. Yes, and then we were in the neurosurgeon part of the world, and I've never seen a neurosurgeon before, so yes, this was new for all of us. It's frightening, by and large. It's just, you hear about these things, but you don't imagine they happen to you. So the neurosurgeon's recommendation was resection, removal, and what he had told us is that once it's removed, let's talk about it that first, right? It's a central neurocytoma is what he has in the pineal region, right? Would that be a fair?
Pineal, yeah.
Pineal region, there you go. Yeah. Probably between 2 and 2.5 inches in diameter. So it was large. But the doctor says it's a very difficult operation, but our expectations are that once it's removed, he'd spend a day in the intensive care unit, probably 3 or 4 days in the step-down ward, and then he could go home, and we could just carry on like we had before all of this started. Our experience couldn't be further from that. It's the reality of it. Yes, so on the 2nd of March this year, 2018, he was taken into surgery to remove the tumor. 7 hours? 7 hours later, so surgeon comes out, said everything went fine, he's starting to wake up, he's in recovery, you'll be able to see him in 20, 30 minutes or something like that. And 20, 30 minutes turned into 40, 45 minutes, and then it was more than an hour. And then I just demanded, no, we want to see what's going on. And so there he is in recovery, and he hasn't woken up. And I said, well, talk to him, encourage him to wake up. And no go. Another hour or 2 later, they moved him into the ICU, and for the next 2 months, he wasn't awake. And so it's every day at the hospital for hours. It's was a huge burden, right?
Mm-hmm. Yeah, but a long story short, he was in a coma for more than 2 months.
Correct.
And then after he was medically stable enough to be moved, he was moved to, still comatose, to Jacksonville, to Brooks.
Well, before we get even to how we moved to Jacksonville, the neurosurgeon, they tried, so he had a drain to drain the spinal fluid that's around the brain. There was some infection risks. He got some pneumonia while he was in the hospital. They never told us this. They just, infectious diseases guy was just there every day, pumping him full of the worst kind of antibiotics you can imagine. He developed what is called neurostorming. And so best way I could describe that is just a bit like a panic attack in a way. The heart rate goes up to more than 200 beats a minute, profuse sweating, shaking. It wasn't a pretty sight. And the hospital kept treating it as though it was a seizure, with huge amounts of it's a type of drug that makes you sleep and calm you down, like fentanyl and these kind of things. What's the word I'm looking for? Sedatives, right? Massive amounts of sedatives. And then any kind of response, minimal response we were getting from him was gone. 3 or 4 days, he would just be like completely gone. And then we'd do it again. And so I worked with the ICU doctors that were there and said, we can't keep sedating him this way. Is there a way that we can just like control his heart rate and bring his breathing level down without knocking him out for 4 or 5 days? We're trying to get him awake. We can't keep sedating him. And that's where the concept of neurostorming came in, and alpha and beta blockers came in, and so we could control the heart rates and do all of those things without sedating him. There were moments of minimally conscious state while he was there. He could watch some TV, he would smile a bit, but for the most, very unreactive, unresponsive. The drain had to be removed because of the infections that were coming, and so they put in what's called a VP shunt. It's some automatic, drain they stick on the back of your head, and they push a pipe down into your stomach, and so the brain fluid drains that way. Then they continue to measure the pressure, and they say no, still not right, so back into surgery. That 1 hour, put a new one in. In the meantime, there's other surgeries. It's the pipe in his mouth to help him breathe still from surgery has to come out. The tracheotomy has to go in. You still see the marks today. Peg tube got to go in so he can essentially eat. I'd like to think it had a flavor of hamburger and chips, but somehow I don't think that's true. And eventually the neurosurgeon, in my mind, just said, okay, there's nothing more we can do. Long-term acute care facility is what he said. Right. LTAC is the word they used, and that's what it stands for. And so my wife and I, we went and toured a few of these facilities, and there was no way we were going to send him to one of those. It's like...
in a crude way, that's where you send someone to die. It's literally they just go there and be kept comfortable, and they don't, in my mind, people don't really come out from there.
So we said absolutely not. He's not going to one of these. We visited a number of facilities around the state here in Florida, and the best that we could find was 4.5, 5 hours drive away up in Jacksonville, Brooks Rehabilitation. Very few places would take him. Another choice was Memorial down close towards Miami Way, there where the airport is. But his coma score was too low, and so they're saying, no, sorry, can't help you. And so our options of places to send him were limited. And so from like 5, we're now down to 3 because of his level of consciousness. And then we're down to 2 because of medical insurance and who's in network and who's out of network and all of these kind of things. At any rate, so we settled on Brooks. And yeah, we put him in an ambulance, and it was 5 hours in an ambulance all the way up to Brooks Rehab in Jacksonville. Once they got there, they said, we're going to hold him for 10 days. He's really not close to conscious at this point. right, we'll work with him for 10 days. If after 10 days this hasn't improved, we'll train you on how to deal with him at home. And that was a frightening prospect for us. It was just like, there's no way, right? There's no way our home environment, we've got stairs and all kinds of things that go on that just don't make it possible. We've got 2 little girls at home. No. As it turns out, we didn't have to go that route. Yeah, another stroke of luck. So Brooks has a program where they measure minimally conscious people. They actually force them to sit up. They've got like loud horns. They do pinching for pain. They make him fall. They don't let him fall, but they give him that sensation of falling over to see if there's any kind of response. And they measure those tiny responses over that 10-day period to see whether this person is close to waking up or not. It turns out that that intervention, in 2 days, he was awake. Very stiff. He'd been in bed for 2 months, right? They'd done some range of motion stuff, but he'd been in bed for 2 months and hadn't moved. Yeah, so he was awake. So we shuttled backwards and forwards to Jacksonville twice a week to be there to support. They one family there for the recognition, to encourage them, and rehabilitation started. At this point, I would say that around the time that we left RA Medical Center and moved him up to Jacksonville is when I first found you, Mr. Crowley. I'd done research online, and it was like, this is good for hyperbaric oxygen treatment. It's good for near drownings, people with strokes, all kind of neurological. And it's not only your website. I found it in a ton of places, right? The same kind of information. And you were one of the ones that were closest. You were kind enough to see me. And then I just ended up with a wealth more of information. It was like there were brain scans, studies, all of these things that could augment the information that I had received, that made it certain for me that this is the path we wanted to take him on. While he was in Delray, I spoke to the neurosurgeons and these people looking after him, saying, is there a way, while he is in this state, that we can get him into an oxygen tube? And they're just dead against it. They don't believe in it, they don't trust it, they will actively encourage you not to walk that path. And because he's under the care of one doctor, if that doctor doesn't, first you've got to get it prescribed, and he's not going to prescribe it because he doesn't believe in it. And it was impossible to get that doctor to work with us so that we could check him out for an hour or 2, whatever it took, to get him to a tube and put him in a tube. And absolutely will not work with you on it. You recommended a book, I forget its name now, about hyperbaric oxygen treatment.
That was probably Dr. Philip James's book from Scotland, Oxygen in the Brain, The Journey of a Lifetime. That might have been the book.
No, there's another one. It talks about fallacies of it and the truth in the fallacies.
Yeah, well, there's quite a lot.
There's probably a ton of them, but
yeah.
This one was hot off the press at that time, and you said, read this book. And so with him going to Brooks Rehab, right next door to Brooks, Brooks Brown is the guy who developed and built the place. And at the point he also used to own the hospital next door, also called Memorial. And so I go and look up at Memorial. Guess what? They've got oxygen tubes there. All right, so maybe there's a chance. So buy the books, take your articles, take all of the studies, the doctors that are taking care of him in Brooks Rehab. I'm saying, here's the articles, here's the study. I bought him a copy of the book. I said, gift for you, have a nice day. Once you've had a chance to review the material, let's have a conversation. Unfortunately, their attitude was no different. And this is a brain injury specialty place, and even they have no support. And there's a bridge that connects Brooks to Memorial. It's the easiest thing, you just wheel his bed down and pop him in the tube. No way of bringing him here. It's more than 300 miles away. And so Brooks, he went from strength to strength to strength. They've got all kinds of rules where family can't assist with the rehab when there's not a therapist nearby. It's liability and all of these things. So he would get 3 hours a day of intensive therapy, occupation therapy, physical therapy, speech therapy. And, but there were other hours in the day, and so as family we spent time mimicking what the therapist did, breaking all of the rules about not allowed to do this, not allowed in the gym. And they kicked us out many times, but we kept going back. We bought him a recumbent bicycle. I've got a truck, so I'd keep it on the back. And so when there was an hour or a 2 hour gap in his therapy sessions, we were allowed to take him downstairs and walk around. So we take him downstairs, we put him on the bike, we strap him in, and we saying, "Ride, my friend, ride." And there he sits today. And so I'm disappointed that we could not get him into oxygen therapy sooner, but without the support of the medical people around you, it's hard.
And did you notice once you started Hyperbarics?
Well, once we got him home and we've got him settled and we've got him ability to like teach him to walk stairs and things so that we could be mobile, your door was the first one I knocked on and said, "All right, so when can we start?" And so I know your view is that the sooner the better, and I agree with that, but in our circumstances, when we got him here was the soonest we could get him here. He hasn't even finished the full course of treatment yet, but the changes that I can see are remarkable. You'll see I've got my notepad here because day one, this is what we're seeing. Day two, this is what we're seeing. Day three, this is what we're seeing. And so yes, definitely I can speak to those changes. And because he's living in our home, even those little changes are very, very easy to notice because you're watching closely.
So let's talk about that.
Yeah, sure. So one of the points I wanted to raise on there is the term spasticity. All right. Nowhere through this whole process, not neurosurgeons, not the rehab doctors, not anybody ever mentioned the word spasticity. He didn't exhibit any of the signs of spasticity, right? And so he starts getting these pains, and he starts sitting like this, and it's just like, what is this? What's going on? Yeah, spasticity. What is this? So we speak to the neurologist who says it's spasticity. There's nothing you can do about it. Yeah, take some pills. Right? If it's not good enough, we give you more pills. If that's not good enough, we can install a pump. Right? And I said, wow. Okay, so like oxygen therapy was like now high on it. And so I mention that because like we don't know about it. We don't know how to deal with it. We don't know how to fight it. And I got more information off your website. Where we see other patients of yours that have been seriously afflicted by spasticity, and you see the different images of where they started and where they are today and how they've completely like loosened up. And I was more convinced than ever that this is the way to go. And so on day, so what spasticity does is it locks him in his body. And it attacks in like phases. It bites and then lets go, and bites and lets go, and it gets you when you're not looking. And that's how his hand ends up like this, right? Because it's when he's not looking. It's like an automatic thing that starts to go. And after the first treatment, the first thing I saw was because his body's locked. Physical therapy is hard. He's down to a little shuffle because it's too painful to take a stride and to walk. And to build his strength and endurance, you can't do it with a shuffle. And so like after day one, that's my note there, was his legs, right? He could take a decent stride. And when he walks, it's it's that pain that he's feeling from it. And all of day one, that took 2 steps back, and I was seriously impressed with that. So bigger strides. So physically, that was the biggest impact I've seen so far, is that it's not gone, and not yet at least anyway, right? But it's loosened its grip, right? And now I can power walk with him now. I can grab his hand and say, right, now we're going to walk. And he can walk, and he can do a good 100 yards at a power walk pace. A month ago, there was no chance, none whatsoever.
I mean, just him sitting here, his arm is relaxed and it's on the chair, it's not into his body the way it used to be. So, I mean, you can see that's a huge improvement.
How do you feel, Matthew?
Timothy.
Timothy, how do you feel?
Good. My neck is hurting.
Your neck is hurting from where they put the trach in your throat?
I don't know, but it's hurting.
Yeah.
It's probably spasticity.
And my butt is hurting.
Oh, okay. Well, that's good to know.
So that's a big muscle group, right? It's prime candidate for spasticity.
Yeah.
Things that I've definitely seen is he is more cognitive. He's definitely remembering. Yesterday we had a conversation about the day before, and he remembered that. I mean, this has not happened ever. Timothy, it was hard for him to remember a minute ago, an hour ago, and now we're getting to a point where we can remember conversations more than 24 hours ago. So to me, that was amazing.
And we've only had like 11 treatments so far.
Exactly.
And so that is, to me, that's still very in the beginning. So we have a long way to go. And so I just think you'll continue to see, my experience will be that you continue to see a great deal more improvement. And did you ever use the median nerve stimulation that I recommended?
Yes, of course.
Okay.
There were some other treatments that you had recommended way back in February, March when I was here. He was still in a comatose state at that point. And one of them was median nerve stimulation. It's as you take like a TENS unit, and people do it for exercise and a bunch of other things, and you put it on the 2 fingers, your 2 front fingers, on your thumb, and then on this meaty part, if I can call it that. You've probably got a nice fancy name for it, but this meaty part of the hand, right? And so even from the time he was in Dalray Medical, in a coma, we started doing that with him, and just kept going a few hours every day. And the recommendation in the study that you had provided, I said, don't do it at night, keep him awake. And so it's a good 2-3 hours every day in the mornings. You go there. Hospital doesn't support it in any way, but you can sit in his room, and so while you're there, you just plug it on and you keep going. There's so many interventions at the same time. I can't say that this is what helped, but this was one of the interventions, and here he sits today. He's not lying in a bed. There was the other one to do with vestibular stimulation. It's about spinning the patient, right? And so when we got to Brooks, I took your study, I gave it to the therapist and said, I'm interested, tell me what you think. And they looked at it and said, okay, we'll talk tomorrow. And tomorrow arrives, and then they say, no, you can't do this to a brain injured person. We're not helping you with it. And so there it is, they're right there. All of these other kinds of alternative things, mainstream medical, you get very, very low support.
Median nerve stimulation was based on research out of the University of Virginia and the University of North Carolina, and they're waking up comas faster, and that was the basis of simply doing that. So it's not like something that's not been approved or documented in research. It's just that sometimes people have their own programs, and they're not going to even read the material that's out there, but there's no harm at all can come from median nerve stimulation. And that goes to the reticular activating system, a part of the brain stem that allows us to focus. And also before median nerve stimulation, we were rotating people because that vestibular input, it goes into the reticular activating system to wake up the brain. So that's why we were recommending those things, and it's not just something that we dreamed up overnight. It's based on solid research. But
Certainly,
why
but-
people elect not to do it, I don't understand.
Yeah, no, and me, father, I elected to go for it, but unless you've got some support around you,
Yeah,
I mean, spinning a patient around can be an unsafe thing if you're not doing it
Oh, sure.
in the right place with the
Right.
right equipment. And
Exactly.
so it's not something I could do on my own. I
Right.
definitely needed support elsewhere, and that support is very far and few
Yeah.
between to find it.
well, do you have any questions? Any-
One thing I would like to add is just that we've seen an overall better, I almost want to say Timothy is happier. He's definitely more humorous. He is making jokes with us, which is not something that we've had in a very, very long time. And he's got a bit of a dry sense of humor, so not everybody gets it, but that's something that's definitely come out the last week, I would say.
Well, that's great.
So it's still early in treatment time.
Yep.
All right, and what I was talking about earlier is, like, from a physical perspective, this is still early in the program, was that we've released some of the grip of that spasticity. And so from a physical level, that's the only thing we're seeing so far. But the rest, and there's a lot of other improvements, and I've got the notes and I've made some key points. I'm going to mention each of them for you,
Okay,
right? But the rest of them are, how can I say, are all in the mind,
okay,
right? Anything that stimulates from that, right? And so I've got his sense of humor returned, right? He has an improved disposition, like just his normal attitude as he sits, right? And it's pleasant, right? You'll see this tumour's affected his eyes, and his eyes a little off, right? And so with the glasses that we got from the optometrist that didn't tell us to go to the neurosurgeon way back when, we'd been using those glasses, and you put tape over the one side. It's called occlusion, right? So that he can see in focus, because he's getting two completely different images with his eyes not being aligned. Right, on day 2, glasses with the occlusion are gone. He still has some double vision, but it's manageable. And so now his eyes have the opportunity to train themselves and realign. With that occlusion on, it doesn't happen. Day 2, glasses were gone. We take him for physical therapy. The instructions, he could tolerate, my words are, tolerating complex instructions at physical therapy. In other words, do this, 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 and this. It was like a multiple step thing. And he's now starting to be able to follow that. The thinking, the memory, the motor planning, all of that's all improved there, right? He starts initiating activities, right? He doesn't necessarily know when he's thirsty, or you have to bring him water and make sure he gets enough water in the day. Now he's sitting down, he stands up, he walks himself to the kitchen to find a glass to go and get water on his own, right? That's day 3, right? We've got an island in the kitchen where we sit him and he eats. Because of his eyes, he can't look down. We've got a mirror, so he can look in the mirror and see his plate, because he can't look down yet, right? And so we sit him down to eat, and you turn around and you look back, and he's gone. Where's Timothy? And so now you're going to start looking for him. Oh, there he's made his way to the bathroom.
Yeah, that was a scary day. Kid was missing. He's a large child.
As scary as that is, it was a wonderful thing to see, right? Completely self-initiated and self-executed. His continence has improved, right? For now, we have him on a schedule, right? We've got an alarm, and the alarm goes, okay, Timothy, up, we get you to the bathroom. Now he's saying, hey, I need to pee.